Good afternoon, everyone. Welcome back after lunch. My name's Tracy Roberts. I'm Professor of Health Economics at the Health Economics Unit here in the University of Birmingham. And we've been lucky enough, our unit is to be co-hosting this conference. Now, it's my privilege this afternoon to chair the last session of the conference, the last plenary session as well. So, the title of the session is Ethics, Health, Equity and Universal Health Coverage, Perspectives from Low, Middle and High-Income Countries. Unfortunately, two of the planned participants have been unable to make it. Addis Waldeman from Ethiopia and Jeanette Vega from Chile. But we're still privileged to have three excellent speakers. And we're going to begin the session with Professor Paula Braveman from the University of California, San Francisco, on health inequalities and health equity and their role in priority setting. This is going to be followed by Professor Ole Norheim from the University of Bergen, and he's going to speak on ethics, inequality and priority setting, a perspective from Ethiopia. And finally, we're going to have a response from Dr. Calypso Chalkido from Imperial College London, and so that's the response. So I'd like to introduce Paula. So afterwards, depending on the timings, we may take some individual questions briefly for each speaker and then bring all speakers together at the end.
Hello. Can you hear me in the back? You can? Okay, good. It's on. It's working. And now I will try to find my presentation. All right. Let's see. It's not responding to my tapping slideshow. Yeah. Thank you very much. Well, it's a real pleasure to be here. I'm going to be talking about the challenge of defining health equity, and some of you may be asking, what does that have to do with priority setting? And the point is that if you want your priority setting to be guided by principles of health equity, it's really important to be clear about what the concept is. And that experience has taught us that when we're not clear about what health equity means, resources originally intended for the purposes of equity can very easily be diverted to other ends. Not necessarily bad ends, but not for health equity. So first, I'd like to show you this cartoon because for me, it captures some of the essence of what we have to think about, the importance of a definition. So there's one gent says to another, and it looks to me like they're in a very exclusive, probably all-male club. The poor are getting poorer, but with the rich getting richer, it all averages out in the long run. And the point here is that when we are talking about health equity, health inequalities, or we say disparities in states, we are not talking about averages. Averages are very important, but that's not what the issue is when we're talking about health equity. Okay. You can't define health equity without defining inequalities. So what are they? If you just look it up in the dictionary, so inequalities are defined as disparities, and you look up disparities and they're defined as inequalities. And for both, it'll say differences, variations, and in some dictionaries, you'll actually pick up a subtle innuendo of the feeling that it's not just any difference, it's a difference that is a cause for concern, but it's kind of vague. Now if you look at official US definitions, for example, what the National Institutes of Health has been using, although I think there's a move there, at least at certain institutes, they've adopted their own definition. But when you look at the definition that's used there, it just refers to differences between unspecified groups. And I'll talk a little bit more about what the problem is with that. So we say health inequalities or disparities, but what we really mean is health differences that strike us as unfair and in a very particular way. Now, Britain's own Margaret Whitehead has coined the definition that is just the most succinct and the most compelling, and that has worked very well in a lot of contexts, probably in most contexts. And she has talked about, she's talked about health inequities as health differences that are unfair, they're avoidable, they're unjust. But the problem with that very succinct and compelling way of defining health equity is that it's ambiguous, because ideas of fairness and even ideas of avoidability and ideas of justice can vary quite a lot. In some countries, women don't have rights, and that's considered fair because of it's a recognition of an acknowledgement of their special role. So are all health differences unfair? Some people have said that any health difference that could be avoided, that could reasonably be avoided, that those are unfair. Some have said that. So if I tell you that skiers are much more likely to suffer long bone fractures than non-skiers, are you going to weep with it's such a pity. What if I tell you that wealthy people in London have a certain illness that wealthy people in New York don't? You're gonna come with me to the barricades and we're going to struggle until we conquer about this? Probably not. Well, here's the next one. Younger adults are generally healthier than the elderly. Well, the problem with that one that I see is that the older I get, the more unfair it looks to me. But I don't think I'm going to succeed in organizing a social movement around it. Not right now, anyhow. Men have a shorter life expectancy. Is that unfair? Is that avoidable? In the US, it's been well documented that African American women have higher mortality rates from breast cancer, and that's not just because of presenting at a later stage. It's even stage specific. African American appear to have more aggressive disease, and some scientists think that they have found some genetic markers. Some have argued against that, so it's in dispute. So the issue here, the point that I want to make is who determines what's fair? And do you have to, each time that you say this difference, this is a health inequality that's a problem for health equity, each time do you have to decide that it is fair and document that? And that can be particularly tricky, like that. What if we don't know what the causes are? African American newborns are at least twice as likely as white newborns to be born at low birth weight and to be born prematurely. And I don't think you can find any health indicators, I guess apart from mortality, that are more important than low birth weight and prematurity, because they are such strong predictors of infant mortality. They're also strong predictors of childhood disability, developmental disability, and they've been linked very, very strongly with adult chronic disease. So they're very, very important indicators, but the causes are unknown. There are different hypotheses about what might be the cause, but this is not a settled issue at all. So can we call it unfair? There are some that would say if you don't know the causes of something, you can't really call it unfair. You have to know the causes. So what would be some criteria that we would want to follow in developing a definition of health equity and health inequality that would work. So first, I think it needs to be conceptually sound. Secondly, and this is the relevance to priority setting, it needs to be unambiguous. It can actually guide setting priorities. So it can't refer to all health differences, and it can't even refer to all important health differences. And I think that's one of the things that hangs people up often, is they see a health difference that is important, and they don't like the fact that some of us talking about health equity say that doesn't have anything to do with health equity. But equity is just one of a number of considerations that have to be taken into account in priority setting. And one of those non-equity considerations that has to be taken into account is the level of the averages, the impact, the burden on the whole population. But that's not what we're talking about when we're talking about health equity. We are talking about health differences that strike us as unjust and unfair, and I'm hopefully going to make the case to you for a certain way of capturing that. We want, in that lack of ambiguity, we want a definition for health equity and health inequality, since they go together like this, that would capture the essence of the social movements that began the interest in these issues. In the United States, the social movement that began the interest in health inequalities, or disparities as we say there, was about racial and ethnic disparities. And that movement was around justice and injustice. Here and in the rest of Europe, my understanding is that the movement around health inequality started from a focus on classes and the unfairness of having classes leading to differences in health. So I think a definition that's going to work needs to at least capture the essence of those social movements that made us start thinking about these issues. But a definition that's going to work also has to be measurable, and it has to be actionable. And I would assume that at this meeting here, for people interested in priority setting, those would be obvious to you. That you must be able, if you've got a definition that you can't operationalize for the purposes of measurement, there's no accountability. People can say, well, there is less injustice. The situation is less unfair. And if you have no standard, nothing that's more rigorous than that, you can't criticize what's happened and get it back on track. I think that a definition that's going to work also needs to resonate with very widely held beliefs and values, to have very wide appeal, be compelling to the public. At one of the sessions this morning, I think speakers were talking about that gap between what's known actually and what the public thinks, and how important what the public thinks is in shaping politics and what happens, what comes out of the wash in politics. So it's very much the same in this case too. And in addition, the definition needs to be as clear, as simple, intuitive preferably, and compelling, but without sacrificing the above points. That's a very tall bill to feel. So let me just quickly, I talked about the Whitehead definition that, again, I think is the most intuitive and compelling and succinct definition that anyone has come up with. And I think that it has served quite well in a number of situations, in many situations, but it hasn't in some situations. Its strength, among the strengths, are that it's explicit about values. It talks about justice and fairness. It's very intuitive, and it's easy to grasp, and it's inspiring. It's referring to values that are very widely held. But the weakness is that how open to interpretation it is, because there are just very different ideas, not only of justice and fairness, but different ideas about avoidability. Because you might say to me, well, the poor will always be with us. And I might not agree with that. So the avoidability is a very contentious issue. Avoidability according to what criterion? And it can't, because it's ambiguous and open to interpretation, it can't be measured, so it can't be used for accountability. Now, the definition of health disparities, and that's the word that's used in the legislation that created a National Institutes of Health Institute for minority health and health disparities. So in the legislation that created that institute is a definition of health disparities that's also been the one that has been most used by the NIH, although I have seen different institutes coming up with some of their own definitions in the last few years because they recognize what the problems are with this. So the way they're defining health disparity as a difference in prevalence, incidence, or severity of disease among different populations. And the strengths, one could say that a strength of this is that it avoids ideological controversies. It's pristine, right? Sterile is another word to use. And that in a certain political environment, that would be good because it's keeping these efforts for social justice under the radar screen when there are forces that might mount a backlash if it was framed separately. And I am quite sure that that is why this definition was crafted that way. I would be willing to bet a lot of money that that's why they came up with that definition. It was a political consideration. The weakness, though, is that it doesn't articulate the values. And sometimes you have to be clear about the rationale in order to defend something. Much as that may expose you, that sometimes you really have to be clear about what the rationale is. And it gives you no guidance on resource allocation priorities. So according to this definition, the skiers and non-skiers thing would qualify, right? And the elderly and the non-elderly would qualify. And people with diabetes have worse health than people who don't have diabetes, right? So that's a difference in the prevalence, incidence, severity of diseases among different populations when you consider the possible complications of diabetes. This would say that if there's a disease among the wealthy in London that's not there among the wealthy in New York, it's the responsibility of WHO immediately to mobilize resources to do something about that unacceptable disparity or inequality. So it's any difference. In a sense, that definition comprises the whole of epidemiology, right? Differences in the occurrence of health or differences in health across different populations. So it's all of epidemiology. Now, there's a definition in a document called Healthy People 2020, and in the US, and every decade, a document comes out of the Department of Health and Human Services, which is supposed to kind of sum up the progress or lack thereof in health during the previous decade and sort of lay the blueprint for what the big agenda items are going to be for improving health in the decade to come. So in Healthy People 2020, health disparity was defined as a plausibly avoidable, and why does it say plausibly avoidable? It's to answer that issue about how subjective avoidability is. It's defined that what plausibly means is that given the best current scientific knowledge and not considering whether there's the political will for something, is it, at least in theory, avoidable? So a plausibly avoidable, systematic, so meaning it's not just random, it didn't just happen once to one group. It's systematic health difference that adversely affects a socially disadvantaged group. So it's a very particular kind of health inequality in which you have the comparison between a disadvantaged group and more advantaged groups, and the disadvantaged group does worse on health, and that pattern is there systematically. So the strengths of this definition are, I think, that it's explicit about the values, but it's not accusatory, because it's not very smart for us to be accusatory, because it tends to turn off segments of the population whose support we might otherwise gain for common goals. It doesn't require proving causality. And that's a trap that I see people falling into very often about health equity or health disparities. They will define a health inequality as a difference in health that is caused by social disadvantage, or by exclusion, by discrimination. And the problem with that is that it is often very hard to prove causality, and that there's a huge proportion of the very important health indicators that we would want to do something about, for which the causes are not currently known. So you don't want to have to prove the causality. This is measurable. We can measure social disadvantage. We can measure accumulated wealth, income, education, and well-documented histories of X or Y or Z group having suffered discrimination, having been disenfranchised, having been the victim of hate crimes. We can look at the representation of a group in high executive office or in high political office, if we want to answer the question of who's in power and who's not, who's disadvantaged, and it's actionable, really, because of that measurability. But the weaknesses are what I have found. I actually coined that definition. The weakness is that it's not very intuitive, and I've just seen that time and time again. People's reaction to it. It's not very intuitive, so it's kind of complex. I've wondered about, well, what if you just made it a little more user-friendly and said worse health in a socially disadvantaged group? Would that take care of the problem? And we'll go on to think about that. I think I'm going to skip this and this and this and come to this. What I've said is that it's really important that there be a firm conceptual basis for any definition. I think that there is, and that it has to do, it's the field of ethics, and certainly there are concepts from the field of ethics that are very important in defining health equity. But I think where we get the most direction is from human rights. In the field of human rights, international human rights, you have both the social and economic rights and the civil and political rights. And those social and economic rights include the so-called right to health, the right to achieve the highest attainable standard of health. But they also include the right to education, to a living standard that is adequate for health, the right to share in the benefits of progress in your society, and other rights which basically are about the social determinants of health. And so that if you take seriously those rights, then that justifies why it is with health equity that we know that we cannot achieve health equity just by achieving universal coverage, or we could achieve equity in access to health care. We could even achieve equity in the utilization of health care and the quality of health care, but we still would not achieve health equity if we didn't tackle the lack of equity in the distribution of the underlying non-medical determinants of health. And that the role of that in defining health equity and health inequalities, I think, can be justified based on human rights principles. Very important human rights principle, another very important human rights principle is that governments should progressively remove obstacles that are in the way to everyone fulfilling their rights. But specifically, the government has even more of an obligation to do so for those who face more obstacles. And that's a crucial concept to explain why it is that we're focusing on the disadvantaged, the excluded, the discriminated. And then the principles of non-discrimination and equality, and the fact that these principles prohibit actions, not only actions with the intent of discriminating, but the effect, actions that have the effect of discrimination. And that is very, very important because it's hard to, maybe it's even harder to prove intent than it is to prove causality in the field of health. Okay. And the human rights principles, I think, also indicate which groups are relevant to health equity. Are the groups the skiers, the wealthy people in the city that, has this problem that the wealthy people in that other city don't have? Who are the groups? Are these the groups that we should be thinking about when we're working on health equity? People with autism, a very vulnerable group, right? But that's not what we're talking about when we talk about health equity. So the groups are referred to as the protected groups, and human rights instruments specifically call out racial, ethnic, by skin color, religion, language, nationality, national origin, the poor, by gender, sexual minorities, age, disability, rural location, and political affiliation. And the human rights instruments do not specify why it is that these groups warrant that protection and why we should be most concerned about them. But I think that it is very clear from reading what is written in the human rights instruments that these groups are the groups that need protection due to a history of discrimination and or marginalization. So some examples would be groups that have experienced slavery, genocide, hate crimes, restricted voting rights, expropriation of their ancestral lands, slurs, racial slurs, or intergenerational poverty. So I am, because my time is up, I'm going to end with this to say that a lot of, often the issue of health equity, defining health equity and health inequalities has been approached as a technical issue. This happened at WHO in the early 2000s. And it could have had really devastating consequences, but it ended within a few years. But it was an attempt to define health inequalities and then by extension health equity in a technical way. And many people, including people who should have known better, were taken in by this. And we definitely need a very firm conceptual basis and a firm technical basis for our definition of the concept of health equity and how we operationalize it for measurement. But we have to acknowledge that the concepts are based on values. There's no getting around it. And that's what I think people at times have tried to get around. That's where that definition that NIH, National Institutes of Health, uses has come from, is people wanting to approach it as a technical issue and not wanting to talk about the values. And the values are that basically that equity is the ethical and human rights principle that underlies a commitment to reduce inequalities. Okay, so equity is the goal. That's the principle that underlies the commitment to reduce the inequalities. And another way of saying it is that equity is fair and just, which ultimately has to be equal opportunities And during the Q&A, if people are interested in that and talk more about that concept of opportunities, the opportunities for everyone to be as healthy as possible. And it requires removing obstacles to health, a societal action to remove the obstacles to health. Health equity can be thought of as the absence of inequalities in health and in its determinants. And its determinants constituted not just by health care, but by the social determinants as well. There are big implications for moving the public and policy and resources. I think of not being clear about what equity and inequalities are about. And you can think about it in this way, that if you're trying to approach universal coverage, if you're trying to approach equity in health in general, even beyond equity in health care, you're going to be swimming against the prevailing tides. And so the prevailing tides are those guys in the cartoon at the beginning. It's wealth and power, vested power. And so you will encounter resistance, very surely. If you don't need to know where you're going, where you're headed, and why, you can easily get lost along the way. So I look forward to discussion with you during that period.
We'll take one quick question if there's a burning one. If not, there's time at the end to discuss. Has anybody got a burning question they need to ask now? No? Okay, we'll ask it again. Thank you very much.
Is it on? One, two, three. Can you hear me? Excellent. Okay, thank you very much, and thank you for inviting me. Sorry. So, I'm talking on behalf of Dr. Addis, who couldn't come because he didn't get a visa here to the UK. And that's probably because there is some political unrest also in the country. So I'm giving this talk with that as a background, actually. So Dr. Addis was the head of the Minister of Health's office for 3 years. And he has a very good grasp of the healthcare system in Ethiopia. And he was invited to a conference where we presented a document called Making Fair Choices on the Path to Universal Coverage. And he really embraced these ideas. So since then, we have worked together on priority setting in Ethiopia. And we work as a group. I'm the lead of a group at the University of Bergen called Global Health Priorities. So I also present a few results from some of these terrific PhD students that we have in the group. But I like to start with a story. So a few years ago, I worked as a medical doctor in the southern part of Ethiopia. More than 80% of Ethiopians live in rural areas, while less than 20% live in the big cities. And there are huge contrasts. This is from a new metro, a light railway they built in Ethiopia. It's the first in Africa, so they're very proud about that. But of course, there are disparities, inequalities, inequities in health and access to healthcare in these two very different contexts. And I worked in a rural hospital, and there's one thing that I will never forget. We had a kind of intensive care unit, and in that unit, we always had 1 or 2 patients dying. We didn't have a lot of equipment, and they were dying from tetanus. This picture shows one of the patients. He was a farmer. He just got a rift in his skin while working, and he developed this disease that all of you have a vaccine against. And you will probably be exposed to that risk, but because you have that vaccine, you will never get the disease developing like this. And it just illustrates for me what we take for granted, that there is a healthcare system out there taking care of a lot of the risks we never see and never experience. And realizing this in Ethiopia made a big impression on me because you see people dying unnecessarily. These are avoidable. So that's one kind of background. I'd also like to present a positive picture of Ethiopia and developments in global health, some challenges, the policy response, and relate this to priority setting and inequality. So I'll show first, based on a study we published last year on mortality trends during the last 40 years. And this graph shows for the world under 5 mortality, mortality between 5 and 49, between 0 and 49, and between 50 and 69. And what's striking is the positive picture. There are huge improvements in mortality. This is for the poorest World Bank regions. You see this plateau here is caused by HIV in the 90s, before treatment became available. But you see these very positive improvement, and it's not only in under 5 mortality, it's in all age groups. This shows under 5 mortality. And this shows Ethiopia. In 1970, 25% of under 5s died. Now it's around 7. Too many, but it's a huge improvement. And the same for 0 to 49 and 0 to 69. So premature mortality has dropped dramatically. So in Ethiopia, life expectancy in 1990 was 48 life years. Now it's 64. Huge improvements. So there are very positive developments in global health and in a lot of countries, as you can see. But there are also challenges. There is inequality, and I think all of us would say this is inequitable. Access, and this is just one example. These data are collected regularly, demographic health surveys. There will very soon be a new study published from Ethiopia. This shows skilled birth attendants, whether women giving birth have someone who knows what to do if something happens. And we can see that the richest quintile have about 50% coverage, but it's extremely low in all the other ones. So the level is very low, and there's a social gradient. This is a very typical pattern. There's also unequal financing, and I think we tend to focus a lot on health, but we should also focus on income of people. This graph is from the National Health Account for Ethiopia, and for HIV/AIDS, government money provides some, but the rest of the world, PEPFAR, the Americans, Bush provided a lot of these. But look at this. Household expenditures is 2%. For child health, all child health interventions, which should be top priority. We know there are so many good interventions that we could use. Household expenditures in Ethiopia are almost 50%. So people pay out of pocket. And in principle, on paper, these are free, but they are not free in practice. And that's, of course, a big unfairness, because treatment for AIDS should be a top priority, but so should these interventions here. So we see that donors affect priorities, and the way financing is organized affect households to a large extent. And this is a quote from a study by Christina Norheim, and it's a work that's led by Ingrid Miljeteig at my group. She's organizing a lot of qualitative studies in Ethiopia on ethical challenges and challenges with priority setting. And this is an interview with a mother who had to, of course, sell some of her assets to be able to pay for services. And this is services for child interventions that we know are very cost effective, and they are not very expensive. But we and the government hasn't really made sure that these are available free of charge. And that has an impact on people's households. So we shouldn't only be concerned about the impact of poverty on health, we should also be concerned about paying for health services and the impact on poverty. So that's another lesson here. This is from another study, by Eirik Tranvåg, another PhD student. We looked at inequality in survival. And this shows the wealth quintiles, again in Ethiopia, and this shows the life expectancy in the different groups. And we can see that the difference between the poorest and the less poor is about 9 years. But what's striking here is that within group inequality is more than 30 years. And that's a challenge for you, Paula. And I think when we take our concepts of equity and look at low-income countries, and if we only focus on social groups or income groups and look at those differences, what then about these differences here? And I think we need to rethink our definitions of inequities. Why are there so large inequalities even among the richer groups? And should we judge that as unfair or not? I think that's a very interesting challenge. So what's the policy response? As I said, Ethiopia and a lot of countries have responded very positively to the WHO report from 2010 recommending universal health coverage, emphasizing that what's really needed is a reform in the financing structure. That's the key element in this reform, that we have to pool resources together and pool risks together. And in that way, we can have a more fair health system, not only in terms of access to healthcare, but also in terms of people's income and household incomes. And Ethiopia has made an effort, and they've started already by distributing health posts in all villages in Ethiopia with barefoot doctors, so-called health extension workers, that provide very basic services very close to where people are living. So they have really developed an equitable policy as an attempt to respond to these challenges. How can a poor country like Ethiopia really achieve universal coverage? People think it's a joke. When we think about universal coverage, we think about NHS and a very high level of services. Ethiopia is spending only $20 per capita on health, and that includes all the donor money. But the idea here is that we have to at least expand towards universal health care. And the idea that everyone should be included and no one left behind, and that we should have, as the rights people talk about, a progressive realization of the right to health, a progressive realization of universal health care. That's the idea. And in thinking about where to start, WHO asked a group of philosophers and one economist, a human rights lawyer, to give advice on this. Norman was involved, and another former PhD student, Trygve, was the lead author on this report. And in the report, we argued, so just to summarize the key message, which Ethiopia really liked and adopted, that you have to set priorities if you want to move towards universal coverage. You cannot include everything now, and especially not in a country like Ethiopia. And you have to introduce mandatory progressive prepayment with pooling of funds and expand coverage for high priority services first to everyone. So that means that those who have to sell their sheep to get access to child health care, they should not need to sell their sheep. So the top priority services should be expanded to everyone without any co-payment before we start doing renal transplants or dialysis or more advanced things. And that's a radical message, but I think you at this conference, you will agree. But this was the message that we presented. And that had never been said before in all this hype about universal coverage. People don't like to talk about priority setting, but we did, and it has been, I think, accepted by many people. And when you expand, ensure that disadvantaged groups are not left behind. So that's the main message, a progressive universalism, as it has been called. We also suggested 3 criteria for priority setting. There's been many of these lists in this conference, so here are our list. And we discussed a lot, and it's when you put 15 philosophers together who are trained to disagree, it's very hard to get some agreement. So, but it's a rough recommendation pointing at some dimensions. All of us agreed actually that the average or the total level of health is important, and that health maximization using cost effectiveness is extremely important, and especially maybe in low and middle income countries. So we recommended that we should start with cost effectiveness, but then include distributional concerns. We should give some extra priority to the worse off, either defined in terms of health or in terms of poverty. And then third, adjust for financial risk protection. Providing these services to the child can protect the family so they don't need to sell the goat or whatever they need to sell to finance services. So that's another criterion. So with these 3 criteria that are based on principles of health maximization and health distribution, I think we achieved some type of agreement that these are the directions we should go, at least. And then we can disagree about the details, of course. And now I'll tell you a little bit more about the details. So how do we define the worse off in terms of health? What I have done here, and those who are interested in the report can look at it, I present it slightly differently here. But we often tend to talk about distribution between poor and rich, or rural, urban. I think when we talk about priority setting, we also could think about distribution and inequalities between diagnostic groups. So who are the worst off in terms of disease-specific life expectancy? Those who die early, typically this is average age of death for measles, for meningitis, for injuries. You can see here, many of them have short, on average, those who are affected by these diagnostic groups or these conditions, they have a short life. They are worst off compared to those who are here, those who on average, those who get prostatic cancer on average will die much later. So this is one, again, quite controversial, but it's one very precise way of defining who are the worst off. And if we are interested in reducing inequalities by giving more priorities to those who die early or those who suffer much from disability, we can reduce these inequalities. Another way to define the worst off would be in terms of both health and poverty. And this is just to give you an idea. What are the typical diseases of poverty? So what we did, we took, well, this is not from the report, but I've taken here DALI rates from low-income countries and high-income countries. And when you look at the ratio here, you see that, of course, war, these diseases here, maternal disorders, age, etc., they are many, many times more common among low-income countries, the death rates and the DALI rates, compared to cancer, for instance. That's almost the same. But also cardiovascular disease, there's a rate between 2 and 3 for these diseases. So cardiovascular disease is not only affecting the richer countries, it's also affecting poorer countries. And now we see a demographic transition, so that's another challenge, a double burden of disease in these countries. So these are things that we need to take into consideration when we want to apply priority setting criteria. Who need financial risk protection? Is it only those who buy very expensive services? Solomon, an excellent PhD student who have been supervised by Kjell-Arne Johansson, did a very nice data collection of people going to facilities with pneumonia and diarrhea. And the average direct cost, it should be free on paper, but the average cost for a mild episode of pneumonia was $8, $6 for diarrhea, but $63 and $79 for inpatient care. So if they were really sick, they had to pay a lot. And in an Ethiopian setting, $60, $70 is very high. So that means that a lot of households never access these kind of services. So again, having these services for free would provide financial risk protection. How can we put this together? So in my research group, Kjell-Arne Johansson, together with Stefan Bergen and Dean Jameson, have developed something called extended cost-effectiveness analysis. That's a very exciting tool that can bring together information about cost-effectiveness, impact on equity, and financial risk protection. And I don't have time to explain and go through that method. I just want to point to that because we talk a lot about inequality, about inequities, and integrating these concerns. I think this is a very promising new method. I'll just show you one example from a study that Kjell-Arne did in India and Ethiopia. So, and the simple trick is just instead of looking at averages and looking at cost effectiveness, in extended cost effectiveness, they divide up the population in 5 groups. So you kind of have 5 populations. So you have to rerun all the analysis 5 times. But then you get more interesting information. And what you find here, this is for rotavirus vaccine. And if you introduce it, these are the poorest. These are the less poor. It's more effective in the poorest groups because they have higher risk. So in this case, it's not really a trade-off between equity and efficiency. It's actually better to provide it among the poor. So you have better outcomes here. On the other hand, if you look at private expenditures averted by introducing a vaccine, you see that among the richest, you provide more financial protection because they are those who usually spend money on health services. And how to weigh all this together, that's a theoretical challenge that I'd like you to help us to solve. So the idea now with extended cost effectiveness analysis is to present these kind of results in a dashboard, and then we can have discussions, deliberations on how to interpret these results and make decisions from them. Let me just end up then by, yes, thank you, 5 minutes. Just saying a little bit more on how we think or how we want to do, introduce this evidence in the process of revising the essential healthcare package in Ethiopia. They have a document from 2005. They want to revise it on the path to universal coverage, and they want us to be involved. So our plan is to present evidence from the Disease Control Priorities Project, from WHO Choice, that Tessa has been leading, and from Priorities 2020, our research group's project, and results from Solomon and Miraf and Kjell-Arne and many others in the group. We will feed this evidence into a committee that is charged with revising the package. And I'll now show you just a little bit of some preliminary results. We have done some standard cost effectiveness analysis, and then we have used this idea of giving extra priority to the worse off and looked at how would that change ranking of services. And of course, this is a very simplistic approach, but this is just to exemplify the consequences of doing this. So this is, we've put several cost-effectiveness analyses using the same methods together. So you see that some are very cost-effective and some are much less cost-effective. So just let me highlight this part. And what we did, we added distributive weights to these cost-effectiveness results. And this is the marginal weighing function that we used. So what you see is that basically the red ones shows the distribution-weighted cost-effectiveness ratio. The blue ones are the standard ones. And basically, incorporating distributive concerns doesn't change the ranking much. And this is a very interesting finding because it's often been said, and here is one example of that, that many of the interventions that we have for very poor settings, like for child health, maternal health, the very cost-effective interventions also has an impact on the worst off. So it's very reassuring. But there are also some differences. So for chronic diseases like mental health, the illnesses, depressions, schizophrenia, etc., they have low health and they are among the worst off. And by adding weights to benefits for those groups, they might jump up in the ranking. So here I've just illustrated. I don't expect you to read it. But this shows changes in ranking when you add distributive weights to standard cost-effectiveness ranking. And developing these methods to refining them could be one way to add this important additional consideration of priority to the worst off. We will then, when we have decisions on what should be in the essential package, we will map these services to platforms because it makes a big difference whether these services are provided at the lowest level at primary care or at specialized hospitals. So we need to differentiate the services according to platforms. So that will be another part of the process. And finally, linking priorities to financing. It's extremely important that the top priority services for childhood diseases, for instance, should be completely free. And that means that one have to pay people to travel to get access to these top priority services. But then you will also have to accept that there is some cost sharing and maybe people have to pay everything for the low priority services. So this is based on the existing financing structure in the Ethiopian system. So finally, when we have evidence and some of the structure in place, there will be a process with stakeholders and with criticism and discussion. And that's a challenge in Ethiopia where there is political inequality. Not everyone have the power and the voice to really influence processes. So how we can do that, it's another challenge for you. We'd like to have input and help. And I've learned a lot at this conference on how to organize deliberative processes. So let me end here summarizing. Inequality in health is important. Maximizing health is important. And by applying these general principles to priority setting, in a low income setting, I think we can do a lot to improve the health of a country like Ethiopia. Thank you.
Okay, I think we'll move straight away to the response from Lipso, and then there'll be a time for questions for all our speakers. So, thank you very much.
Right. Wow. So how do I respond? So I'll just give you a few disparate thoughts, and then I think it's better to have a good discussion. And it's the end of the day. So first of all, I think it's great we're having this conference, and these last two talks are super encouraging, certainly for me. There's some people, especially in the global development world, who feel that setting priorities for health is actually unethical. And I think the likes of Jot and I, and most recently in a country that shall remain unnamed, who were accused of being sort of libertarian advocates of rationing. Because at the end of the day, healthcare is a human right, so everybody should have it, all of it. And the likes of Paul Farmer, for instance, who's a very important voice globally, would argue that you should get the same sort of ICU care that you get at Harvard and Boston in Sierra Leone or Liberia. So I think it's important that this conference and this society brings together people from different specialities, including economists and ethicists and practitioners and policymakers. And I only wish and hope that it can be expanded to include colleagues from different countries, including countries who are poorer than the UK and the sort of majority membership of the group. So to respond, so I think what you're saying, Ole, about the fact that perhaps equity and efficiency are not at odds. And I think the empirical data that you have shown does show this to some extent. I think that's very encouraging and important, because I think it would be a great tragedy to argue against setting priorities in ways that are procedurally fair and that are based on some evidence of what works and for whom. Because my question, I guess, would be that if resources were to be allocated to the worst of, for instance, what happens when the diseases and conditions these people suffer from have no treatment, or the treatments for these conditions are hugely expensive and don't work nearly as well as those that are more fortunate, if you like. And of course, there's inequalities in that, in terms of how R&D money is spent and how prices are set for things. But when these choices are made, I think what is very important is to try and quantify the trade-offs. And what we usually don't talk about when it comes to vertical equity is the opportunity cost, is who loses out? And what about equity weights for that loss, the health loss of those people that are not at the table because their condition hasn't been prioritized in the first instance? And I think that's important to consider, and your approach helps by breaking down, as you described it sort of simply, though it is complex, allows one to put the evidence forward and then to discuss. And so my second point has to do with processes. And I think the fact that I believe, at least I hope, that the time is ripe to move away from both sort of technical and procedural solutions that are decided at a global level. If you look at the tools we're using to do the economics globally, we're using the DALI, and experts use what weighs the most there, unlike perhaps the quality or other measures. We're using acceptability thresholds, and I'm not sure you can see Tessa, but the 1 to 3 GDP per capita that the World Health Organization has put forward, hugely aspirational, with very real distortionary effects on the ground, when absolutely everything we look at seems to be cost effective. Very few things are not, when this type of very generous thresholds are used. And this type of aspirational decision making actually could be very bad. If you're an advocate, that's perhaps a tool to push things forward, and miracles do happen, and South Africa in the 90s was one of those cases. But if you look at what's happening now with HIV, we know that about 2 to 3% of the population that is on treatment is treated with very expensive third, fourth generation antiretrovirals. And we know that about 50% of the people who should be on treatment are not at all on treatment. So there's trade-offs there. And who's making those value judgments, and on what? Data. And I think, again, data are important. So let me see my notes. I can't read my own handwriting. I apologize. So I guess what I'm trying to say is that localizing some of these decisions, as you're demonstrating in the case study of Ethiopia, is very important. And there's countries like Thailand, for instance, which of course much richer than Ethiopia is, that are way ahead in that. And I think it's important to hear from colleagues in these countries who have adapted both the methods and the processes to their own settings and are applying them. And I guess one last thing for me to say is, what do we think the role of sort of the global advocacy or global technocratic sort of community may be? And I would put to you that our role perhaps is more to suggest means to an end and allow local decision makers and local technocrats, local civil servants appointed by the local governments to decide on the ends. And I think that's tricky, because you constantly see sort of Lancet calls for X, Y, Z. Every other week there's a big call to do something, it's a priority that comes out. And there's, as you say, this sort of global lists. We know these are the important things. And even if I may challenge you all, sort of value judgment in terms of who we should be prioritizing. You know, we should be prioritizing the worst off. Perhaps that's even there, we're sort of a step beyond our remit of serving people and advising rather than deciding on the ends. And I hope that this conference in the near future is held in a country that, like Ethiopia perhaps, where we can garner enough support for people to participate and also for us to travel over. Because I do think that this type of gathering of people, different backgrounds, is really sorely missed. You either see sort of technocrats, economists mostly working on the financing side, or human rights advocates who feel very strongly about their own little thing, but choose to ignore the bigger picture. So thanks very much for having me. Thanks, Nesting. And I look forward to the discussion.
So can I invite Ole and Paula up? Right, have we got any questions? Would you like to say who you are, where you're from, and
Sure, thank you. So my name is Frithjof. I'm from the Netherlands. Thank you for a very interesting session. In Frithjof, I have a question for you, if I may. Really impressed by the work that you've been doing the last few years. I have one small, perhaps not very unimportant comment or suggestion, which relates to the process that you have been shown. Process for revising essential social standards. It starts with, I suppose, in collecting evidence, analyzing, etc., etc. And then further down the road, there is the stakeholder communication. My suggestion is to try to involve the nervous state in order to prevent what I can call the error of the third kind. Solving the wrong problem, answering the wrong question. And then there is one further comment, and that is, you challenged us, and you said, well, that is going to be very difficult in that particular context. I can imagine that it is, but we've had some experience with reconstructing the frame, which is basically trying to figure out how the various stakeholders define the problem, judge solutions, and how does it relate to their constituents. It could be useful also in your context, because it is a way of structuring and helping in effective people in articulating what is on their mind, to give that a sort of position in the process that is concerned.
Thank you, very useful comments. I just respond. We have already included 2 patient organizations in the group that will ask for evidence and be involved from the start. So we still have the risk that we are presenting the evidence, but we have worked very hard to have this group having ownership of the process and also the values. So it's not that we are imposing values. They have very clearly stated in the documents that they want to move towards universal coverage with quality and equity and efficiency. And this is our interpretation, but they will have to interpret that.
And it's also a way of benefiting from the knowledge that they have that we have. You may have.
Yeah.
Okay, thank you. There's another question here.
Hi, so my name is Alec Morton, University of Strathclyde. I have a comment and a question. So I guess my comment is really more of a personal anecdote. I used to work for an airline, and we did a training program. And I remember I traveled through a number of different regions of the world with this training program, North Asia and West Asia and Southeast Asia. And one of the things that was interesting was that in all of these different countries, although it was the same training program, the same material, people process this in very different ways. So people have quite different attitudes to how you behave in a classroom setting and so on and so on. So I wonder, I'd be interested if you have any reflections on the challenges of organising deliberative processes in countries outside of Europe and the US. These are countries which have very different cultural expectations, background, philosophical traditions, institutions, all that sort of thing. What are the interesting differences that have come up? Or is it simpler than you might expect and it's the same principles apply everywhere?
Maybe both of us. Yeah, thank you. So the cultural differences, one thing that strikes me very often is that I was at one conference on translating evidence to policy in Ethiopia, and the officials reacted very strongly against this idea of involving the public. They are not trained, they don't have the health literacy, and some of the culture is unfamiliar with that notion. So, but these are global ideas that are taking hold, but it's not obvious in all culture. You have other experiences.
Yeah,
Yeah.
So yeah, I agree, and I think I guess that's where some sort of evidence of whether it matters or not, and in what way to do it, would actually be a powerful tool, because we talk to people and advocate evidence, sort of informed decision making, and then we say, well, you have to have a lay person in the committee, and they say, why? And we say, well, because it looks. So it's problematic. So it'd be nice to have some sort of evidence, even though it would be very context specific, but even for our own contexts, perhaps, which may be more developed in that sense, as to which types of, even a taxonomy, different types of engagement, and then a conceptual framework of why we're doing it, and then some methodology for testing this, and then perhaps even some empirical evidence against that to say, well, it works or it doesn't. So yeah, it varies, but it's hard to preach without the evidence.
Yep, Yestin from, everyone knows where I'm from by now probably. Could we give Paula a chance to respond to Ole's challenge in the interest of getting a bit of an argument started?
Okay, do you want to repeat the challenge?
Yes.
Yeah, so basically I think when we move to, maybe everywhere, but in low-income settings, I think that a lot of inequalities can be considered as unfair. And when we see that there are big inequalities in age of death or life expectancy, regardless of socioeconomic class, but within these classes, I wonder whether we should confine our concerns for equity, whether that should be only whether it's associated to these typical causes or not. There is a philosophical position saying that, like Larry Temkin would say, that all inequalities are unfair if they are caused by factors beyond individual control. And in the low-income settings, most of these factors are beyond individual control.
I'm so glad this came up because that position that all inequalities are unfair if they are avoidable, that's precisely, that was one of the scenarios that I was talking about, which has been used to argue against giving consideration to social exclusion, marginalization, saying we're all the same here. Let's just consider health. And that was really the proposal that came out of these people who were briefly at WHO, but that we shouldn't be arraying people according to predetermined social categories. So we shouldn't be looking at comparing the health of the poor with the health of the rich. We should be comparing the health of the healthiest with the health of the least healthy. So it's exactly that idea. And the problem with that is that doesn't take into consideration who has the resources and the power to do something about their condition. So I think if you really believe that equity is about, that it has to do with rights, and you can translate the rights, I think, into the notion of opportunity, who has the opportunity to be healthy, then the resources that you have, both personally and in your setting, to do something about that poor health really need to be taken into consideration. What I agree with you, the data showing the spread of health within those socioeconomic quintiles, I'm not surprised at that at all. For one thing, the way that we have to measure those socioeconomic quintiles is a pretty blunt instrument. And I think it is a great way to look at things and not just accept, the average within each group. But I think, again, and that we have to accept that any measure is going to be imperfect, any way that we categorize people. But we do the best that we can. And economic resources, sort of the best measure that there is of economic resources, the best measure that's there, that's of racial or ethnic distinctions that are tied to differences in power and in wealth. When we look at who's in power in a country in terms of who heads and controls the greatest, the businesses, the big businesses, and who's in political power. You do the best that you can with the measures, and then you do try to keep your antennae out for where you're going to have some fuzziness around the edges. One thing, I wouldn't be surprised at whether the spread that we saw in your slide, whether that had to do with the spread of economic resources within that group, because they all constitute. And you're saying it did. Okay.
Right, I've got 4 questions lined up. There's a lady in yellow, and then the lady in pink.
Susan Gould, the University of Michigan. Craig, if you're listening. I'm curious to know, I know, Paula, one of the things that you talked about in your definition of inequalities and equity was the issue not just of opportunity for health, but also about determinants of health. And your focus, Frithjof, was really on universal health care coverage. And I'm wondering if there's, maybe you just didn't have time to address this, but is there stuff going on in the health ministry also about priority setting to not just the tetanus shot, but the shoes, not just treating the diarrhea, but clean water, that sort of thing that has often an even greater impact on health and on health equity than the health care that may or may not be available.
I thought it was a question.
Yeah, okay. Yeah, so the last point. I'd actually like to challenge that view that that's a typical Michael Marmot view, that most of what you can do for health, you do outside the health sector. Angus Deaton has written forcefully about this and looked at some of the evidence. And especially, I think, in the beginning when new technologies are adopted, I think medical technology and medical services are extremely important in shaping health. And I think we don't have the evidence saying that most of it happens outside the health sector. Vaccines are extremely effective. Pneumonia treatment is extremely effective. And people are dying from these obvious, banal causes. And I think in a setting like a low-income country, I think we can do a lot more about the health system and providing healthcare, including preventive services, before we do revolution and do something with the income distribution. That's harder.
Can I say something on this? Because there's another question.
Yeah.
Sorry, I've got a microphone.
Did you
Right.
want to?
But I've got this one. Okay. But and also, I think the issue of financial protection is important as well, because whether we like it or not, whatever we believe what the evidence suggests, these technologies are penetrating the market. And when there is no framework for managing the way they're priced or advertised or promoted, then you do have, either for good or bad reason, people selling everything they've got. And I mean, when the NHS was set up here, the main argument was, peace of mind and financial. It wasn't you get healthier. And at the time, because we didn't have that much technology, people were not actually getting that healthier either. But as you showed in the 70s and even the 50s onwards, things change. So just a plea for actually some of this. So for instance, right now in India, the current administration is saying we don't need to invest in universal coverage. The country spends, the government spends 1.2% of the GDP on health, and many people, very influential in the administration, are saying we shouldn't spend more because it's all about clean water and this could occasionally be used as an excuse against getting things that work at the right price to the right population group. But I don't know if the Ethiopian government are thinking about population level prevention measures.
Oh, they are.
Okay, we've got the, up there.
I wanted to address this question about...
Name and where you from.
I'm Marion Danis from the National Institutes of Health in the U.S. I wanted to address the question about the wide variance within economic tiers, and I think that it's probably that we need to think with what we intersectionally, that what may well be going on is that the lowest, or at any given tier, you have other variables like gender, level of education, and these are testable hypotheses. That's what's the people at the top of that health outcome data are the males, perhaps, or the more educated. So I think that it's something that can be examined and analyzed, and it's not entirely surprising.
Just a short comment on that. So Chris Murray was the one who argued very forcefully in BMJ in 2001 that we should look at individual inequalities and explore and describe these inequalities. And there are studies showing that about 25% of these inequalities can be explained by a level of education, by income, etc. And a lot of the other, in many studies, 75% cannot be explained. And I think the ethical issue that's very interesting is whether they should be regarded as unfair or not. They are beyond control. Some of it might be within the control of societies, because if we compare Ethiopia and Japan, for instance, we know it's possible to reduce these inequalities and improve the average. So it's the way the society is organized. We know that we can change it. But whether we know all the specific causes, that's another issue. But I think that's an extremely interesting question that we should discuss more.
Okay, thank you. We've got a gentleman next to her, then the lady here, then on there.
Okay, this is a question for Paula. Do you think that someone has a right to health care if they have a genetic disease? And if they do, then rights are not determined by inequalities that you would recognize, and so I wondered what the basis for attributing health inequality, thinking that a right claim was fundamental to it.
I think it's the way that you've set up this example that doesn't quite work. It's talking about whether an individual, every individual has a right to health, and then with that, a right to the determinants of health, with health care being one of those. It's true that everyone does, but when we think about trying to achieve health equity, we're thinking about the societal level and governments and societies' obligations to distribute resources. And I think where equity comes into it is for a government deciding on it, its policy for resource allocation. Are those who, those who have been excluded from society, been discriminated against and excluded from, are they going to,
Aren't you going back to your earlier definition of a disadvantaged group as the basis of talking about health inequality?
Well, absolutely. What do you mean by my earlier definition?
The definition you gave of inequality in about inequalities in health if you're now talking about disadvantaged groups?
No, well,
People who've been excluded.
I think there's a misunderstanding here because that the disadvantaged groups are using that sort of synonymously with the groups that have been excluded or marginalized. That I think understanding that is absolutely essential to understand the concept of health equity, because what it is about is really trying to remove some of the obstacles that those groups have faced, obstacles over and above what the rest of society has faced.
I'm going to leave.
Trying to get at what the role of a human right to health was in defining health inequity, and it didn't seem to me that you clarified that at the end.
If you don't mind, I think we'll leave that one there.
We should talk more afterwards. I think we're not.
Question here.
So my primary comment was actually about intersection. Donia from McMaster University in Canada. My primary comment was going to be about intersectionality and that type of philosophy and theory that's becoming really prominent in North America, maybe more so than Europe. I know there's massive names in intersectionality in the United States. But since that was addressed, I actually had a question that stemmed from the farmer comment in terms of priority setting as a concept of being unethical. And I think perhaps it becomes unethical if you stop at that first tier that you showed, Ola, and said zero cost sharing for this, and that's the end of how our health system is going to work. And once we achieve this coverage, we don't continue down the continuum or try and get more resources. That being said, I wonder if in any of your experiences, you've encountered lessons learned in the opposite direction. So can we take what has been done in Ethiopia or in India or in other global south countries and apply it to Canada, Norway, the United States, where we're spending so much on tertiary care?
Great questions. So I think the first point is very good, that we have to remember that the whole idea about universal coverage is the idea of progressive realization. So we must be honest, and we have to say that we have to set priorities within the available resources, that we want to work for more resources. Of course, balancing resources for health with other social needs. But that's a key concept, and it's important to communicate that. I didn't do that so much to you because I assumed you take the point, but it's very important. And the second point, can we learn things? I think one interesting thing I've learned by working on data from low-income countries is the rich data they have on social on inequalities in health. The demographic health surveys shows coverage levels disaggregated by groups for a lot of services. We don't have that in Norway. We don't have that in a lot of countries. UK is an exception, I think. But I think we should do much more of those kind of surveys also in high-income countries.
I just wanted to say, Sterling Bryan from Vancouver, that trained and brought up in Birmingham, in fact. So there's sort of a great session, and I really learned a lot and enjoyed it. I think the starting point of the sort of tradition of equity versus disparity, or like why we end up thinking in a European context about equity and in a US context about disparities, the sort of like drivers of that was very interesting. And I've always been uncomfortable with the use of the word disparity rather than equity, because from my perspective, it seems to speak more to a descriptive piece rather than a value statement. I mean, and for me, everything here has to be, and I think this is a point you were making, was you have to bring a value lens to this. So it's important to have the description of the variation, but there needs to be a judgment about whether that variation represents something that is seen as unfair and something that should be acted upon. So I wanted to then bring that thinking to the extended cost-effectiveness analysis work, where you're looking at that variation by income quintile, which from a descriptive point of view, I think is very interesting, and probably does have a value lens in terms of a fairness proposition. But when we do cost-effectiveness analysis by subgroup, which in a sense is what it is, we are interested in something that's actionable from a policy point of view. So then you need policy folks to be willing to say we'll have differential access on the basis of income, the income range. So, and I'm not sure that we're often in that position. So I'm just wondering about how effective at influencing policy the extended cost-effectiveness analysis might be.
Well, okay. Yeah. You know, a lot of people, well, the term health equity is very trendy right now in the U.S. and the health and even medical circles, making it all the more important that there's some understanding of what it actually means. I want to speak to the issue of using inequity instead of inequality and disparity. And so a lot of people are starting to use inequity and kind of put down the use of disparity or inequality. And what I like about that is that they're bringing the moral dimension in, which just hasn't been done, at least in the States, until now. So that's a good thing. But unfortunately, for a lot of, it gets back to what, one of the points that I was making, for a lot of very important health indicators, we don't know the causes. And so it's just that it's vulnerable to an attack by someone saying, wait a second, we have no idea what causes this. How can you label it? And inequity is very explicit about this, saying this is unfair, this is unjust. And so that's why I recommend, and what I do, I use the word equity. I think there's no problem when it's meaningful, but I reserve the use of the word inequity for situations in which there's really pretty strong evidence that it would meet criteria for being unfair. And then the other thing that this brings up, it's why it's very important that in your definition of equity, and it's equity as the absence of inequalities or the absence of disparities, it has to work without causal inferences, because it's impossible otherwise, that having to judge each time. So that's where the Healthy People 2020 definition, I think one of the strengths, important strength about that was that we can say that something is an inequality or a disparity, and we're saying that it is unfair for a disadvantaged group to have worse health. It's a double whammy. You need social advantage you need your health in order to escape social disadvantage, making it even more unfair.
Quick response. I agree that this is basically a subgroup analysis. I think one way it can be relevant for policymakers is that if you just are concerned about averages and you have a social gradient in coverage and you improve the average but not concerned about the distribution, you miss out the opportunity. Maybe you can have more effect by targeting the worse off or making sure that they get the services. So I think in general presenting information disaggregated is what policymakers would like to have, but we don't know that yet. Yeah.
Okay, I'm going to go to the last question because the gentleman's been waiting for some time. But if you could keep it fairly brief, and if I could suggest to the panel that it's your chance for all of you to have your last word. So a response from all of you would be great.
Thank you for a great session. I have a question about tax systems, because I'm a bit worried if you remove all the out-of-pocket expenditures, what do you replace it with? Donors that influence the priorities or some kind of risk pooling? And how do you actually scale up some kind of insurance system or tax system in a country like Ethiopia where they don't trust the people who run the tax system? Is that also a financial risk for the people? So it's not a health-related risk, but it would be a financial risk, but they don't get any benefits. So what's the alternative? My worry is that if you remove in Ethiopia all the out-of-pocket expenditures to health, you just cut the health budget with 34%, and then what are you left with? So any thoughts around this topic? It has been bothering me for some years.
Yeah, we should ask Tessa, who's an expert on health financing. So we are not proposing to remove all out-of-pocket expenditures, but those expenditures going to health should go to the top priority services. And the whole discussion about moving towards universal coverage presupposed that you have some ways of finding revenue. And many countries have experienced. A country like Rwanda has been able to collect a small fee for health insurance, and Ethiopia is experimenting with that. They are doing it voluntarily, and that's not so easy. But I agree, that's one of the big challenges in development in general, how to generate revenue and collect taxes in informal economies. So I don't have a good answer, of course.
Okay, and any last word? Any last word from you? Paula, last word? We're almost out of time. So.
Guess what I would like to say is that I am not so foolish as to believe that if we get a really rigorous, airtight definition of health equity, that all our problems are going to go away. I think in a lot of situations, probably most situations, a better definition of health equity is not at all what the obstacles have been. But I have seen situations in which it has made a difference. And typically what it does is make an opening, create an opening for a segment of the powers that be, basically to reclaim resources that were at great cost designated for health equity. And those are the situations in which I think it's really important to be clear.
Okay, well, thank you very much. Thank you, Paula, Ole, Calypso. Thank you all very much for excellent presentations and the discussion. We'd like to thank all our panel. Thank you.